it's interesting that the original step response, the alveolar tension curve that we look at, was really written by the original alveolar step response was originally written by Seymour Ketty in 1950 in the journal Anesthesiology, where he actually gave us those curves that Eager in 1963 then talked about Mack and worked all the way around it. And it's interesting that we don't often appreciate that Eager actually did the inverse alveolar tension curve and showed us that low-flow anesthesia works. And I think we don't give him credit for that, giving anesthesia at 1 Mack, which is an interesting part of this whole wonderful history story. And it is a wonderful history story. But the idea of the step response gives the engineer the full analytic tool, because the step response defines the system transfer function, and its derivative is the impulse response, and it allows all the math to be put together. And I think that's why Eager wanted to teach it to us as a population of anesthesiologists, thinking that it might help, whereas in fact, as Dr. Wolf just pointed out, maybe it has hurt terribly. And that may be true. Why is it on that early curve of nitrous oxide and desflurane, that the very first one, why is desflurane lower than nitrous oxide? I thought its solubility was higher than nitrous oxide.
The solubilities are higher for nitrous oxide. I don't think I did a comparison with...
No, on the first slide. Nitrous oxide is higher than desflurane, but nitrous oxide solubility is 0.47 and desflurane is 0.43. Why are they backwards?
It's because of tissue solubility. The tissue solubility of nitrous oxide is less than that of desflurane.
I disagree.
You may disagree with the explanation.
No.
But the
Oh, yes, right.
solubility is less.
The study was done. It's not very well recognized, but when you read the slide caption from the article, nitrous oxide was given in 70%, and the other drugs were trace concentrations. And this was showing the concentration effect of nitrous oxide,
Okay.
which is actually hidden in that article and almost never recognized.
All right,
And I thought
good
to this
point.
audience it would be worth understanding. Dr. Wolf has taken us so far into it that we wouldn't miss that last little piece.
Good, good. Yep. Yes, Sam.
For isocapnic, you had indicated that adding CO2 is a bit too involved. I understand in Britain they do it. But most absorbers now are self-sealing if you take them out of the circuit. Has anybody done a study where during emergence you take the absorber out of the circuit, and does that give you close to isocapnic ventilation?
But that automatically...
I can add a little bit on this one.
We can't let you talk about it. So there's a device on the market conceived by a group that happened to be in Salt Lake City that came up with a charcoal absorber on the inspired limb, so that what Dr. Lampetang just said, the idea of rebreathing wouldn't be contaminated by the rebreathing of the inhaled anesthetic agent. Right. And it's a fine device. It works incredibly well, and someone in this room has a conflict of interest, but I do not.
No, actually, that's not what I meant. I meant by removing the CO2 absorber from the circuit, you let the CO2 rebreathe.
But if the CO2 rebreathes, that automatically means that your potent inhaled anesthetic rebreathes also.
Sam,
that
to do
defeats
that,
the purpose.
Yeah, to do that, you have to turn the fresh gas flow way down, which then the anesthetic builds up in the circuit.
So I would say that including active charcoal is also tweaking with the system too much for daily use. Just like adding CO2 to your circuit is... I think that most clinicians would not be interested in doing that. And by the way, it's probably not worth it anyhow.
Great talk, thank you very much. As you say, in the UK we used to have CO2 on the anaesthetic machines. And we used to use CO2 both at induction and emergence, but there were various accidents because we used to probably do hypercapnic hyperventilation, and so that was the CO2 was removed. Some people sometimes do take the CO2 thing out. The thing I read an article from Canada a little while ago about treating carbon monoxide poisoning with hypercapnic, isocapnic hyperventilation, and I wonder if you had any thoughts on that.
I think that makes perfect sense. But I would again say that these are kind of exceptional situations. But there are some perfect uses for the use of this kind of technology. I think it's too cumbersome for everyday use in the practice of anesthesia. But there are certain indications for it where it perfectly makes sense, yes.
Joe Fisher came and gave a talk about exactly this situation
Excellent.
1 or 2 years ago. Was last year he was here or the year before?
Are they Canadians? Are they Canadians?
Yes, it's from
Joe,
Toronto.
you have any more comments on isocapnic hyperventilation?
It works when you need it. Yeah, we showed with Dr. Sakata it works very well with the rebreathing and doing it that way. There are limitations to how much CO2 you can get. You don't need it all the time, but there are times, especially when you're teaching a new resident that doesn't realize anything about tapering, that it's a very handy thing to have.
I got the impression this was circuit ambulance men could use. This was the impression I got.
I don't know about that.
Yeah, I think, I think he has his
That's
device.
the Joe Fisher's isocapnic device is that way. This is more of just a disposable thing you pop into the breathing circuit.
I guess I just can't resist. So I'm Dr. Sakata. I work with Dr. Orr. I do have a conflict of interest. It is a company. It is a device. I do have it here if you want to see it. But I do have a conflict of interest. But it has reduced emergence times by 60%. So in those cases where you can't taper, the issue also is that when your patient emerges from anesthesia, they're not hypocapnic. And the reason why that's important in the United States, we have more of an issue with this. Our patients are obese. They have sleep apnea. The only way you rid yourself of these anesthetics is by exhaling these anesthetics. The problem is that our anesthetics make them sleepy. When they're sleepy, they obstruct. When they obstruct, they don't breathe. If you can keep that drive to breathe just a little bit better for a little bit longer, you can get these anesthetics to leave a bit quicker. Now, that being said, we're also working on new inhaled anesthetics at the University of Utah. We're working on inhaled ester-based anesthetics, anesthetics which are not the opposite of what Dr. Eager said. They're completely broken by the bloodstream. The reason why these are important is because in the United States, with obesity being on a rise, that the ability to have the bloodstream rid itself of the inhaled anesthetic innately is of much benefit. So we're trying to do this right now. We've published in rats, and we're looking at moving forward in pigs pharmacokinetically and then in humans. So those are the things we're looking at just because our population is so challenging in the United States.
Yep.
Thanks.
Are you available September?
Great, thank you.
Excuse me?
Are you available September next year?
Yeah, I could be. To come back, I like Belgium, so I wouldn't mind coming back here.